Hello, everyone. So I'm Tran. I'm the Director of Clinical Chemistry and Point-of-Care Testing at the University of California, Davis Medical Center. And there we are there on the first slide up in Sacramento, California. A quick background. We're the northernmost University of California Medical Center. We serve a wide range of patients across the Central Valley. We're a 618-bed hospital, and the number continues to grow as we're growing as a medical center. Quick key facts about us. We're one of the larger burn centers in the country. We also are a cancer center, a designated NCI cancer center, as well as the #1 kidney transplant center in the country. So that we'll kind of call back to in this presentation. Of course, today's talk is on burn sepsis and acute kidney injury in unique populations and the promise of artificial intelligence. Quick disclosures, we have none. The studies I will present to you today are investigator-initiated studies. In fact, some were supported in part by the National Institutes of Health. And I also want to give due credit to Dr. Houman Rashidi, who's also listed on this first slide right here, who's our artificial intelligence expert at UC Davis. So definitely much credit to him, too, with his support of this project as well as this presentation. So moving forward, we have some quick learning objectives. The first is to describe the state of artificial intelligence and machine learning in society versus laboratory medicine. I take it that most of the audience members today are from the laboratory field, so we're going to try to relate to what we've been exposed to in AI and ML in society and how this could impact us today in our professions. We also want to identify practices, and specifically best practices, for developing and validating health-related AI and ML algorithms. And lastly, describe the clinical value of artificial intelligence and machine learning for sepsis and acute kidney injury as it relates to a high-risk population that we're going to focus on, which are burn patients. So let's ask that question. What is artificial intelligence and machine learning? And I think over the last couple of years, and even most recently, the last year or two, we've heard about AI and machine learning all over the media and so forth. We wanted to catch everyone up to the same wavelength here and really define what AI and machine learning is. And what you can consider AI to be is really the overreaching field. In this case, AI is a branch of computer science dealing with simulation of intelligent behavior in computers. It's pretty much giving machines the ability to imitate intelligent human behavior. But where does machine learning fall under? Well, it's a subcategory of AI for all intents and purposes, and it's a process by which a computer is able to improve on its own. So you give it new data, it's going to get better, and then as it continues to move on throughout its use, it will continue to evolve, quote unquote, and become better and better, hopefully. And it uses mechanisms and statistics to achieve these goals. And then last but certainly not least, a very exciting area of artificial intelligence and machine learning is deep learning. And this is the use of very sophisticated AI algorithms, which effectively generate artificial neural networks, mimicking what we have in our brain to continue to learn and become better. And this concept of an evolving machine both creates excitement and also fear by a lot of society. From the fear standpoint, the question comes up all the time, will AI take over? And you can see here with references to various forms of media, movies, and so forth, there is that one day AI could figure out that humans are the threat, as an example, and jokingly, they decide to take care of us, for better or for worse. And this has created unneeded fear in this very revolutionary technology that could potentially help us. But at the end of the day, it relies on how we use it to ultimately dictate what type of effect it has on our society. We don't have to go far, though, to see how AI and ML is already changing our lives. Already, as you are probably browsing the web throughout the day, we have search engines that rely heavily on artificial intelligence. Using Google, for example, here, which is a very popular search engine, you'll see that as you're typing in your search parameters, it's already trying to predict what you, the individual, may want. And oddly enough, what you search, you also see other things that are reference to what you may be interested in. So these are all very sophisticated mechanisms of machine learning and artificial intelligence that are being used every day, every second. We also see social media leveraging artificial intelligence. So from the standpoint of facial recognition, where you post a picture of yourself on certain social media, it asks you, is this you? So it's recognizing features of your face and linking it with you as the individual. We, of course, see certain stores, in this case, online stores, a very large one in this case, identify your preferences for things you want to buy. Again, machine learning, huge role here. Your phone, the powerful technology in your hands, using recently, even as of last night, as I talked about, I have an update for one of my phones saying now it's adding a new software to be able to leverage the deep learning capabilities of this new phone that we purchased. And you can see here, again, it's using this to be able to identify faces and many other features to be able to our daily lives. And of course, we've seen a couple years ago that machine learning AI have also bested humanity in game shows, in this case, Jeopardy. So this is the famous case where IBM Watson beat contestants on the game show. And of course, the emerging evolution of self-driving vehicles. Vehicles that are now driving with cameras all around them, taking many pictures at every frame per second to then determine, is it in the middle of the road? Does it need to avoid a person? Does it need to avoid another car, and so forth? All this is happening right now as we speak, and then some. So where do we start with AI in healthcare? Because we see it now in our everyday society, but what about healthcare? Is AI already here? What do we do? How do we actually get AI going in this very important field? This is a paper that we recently published. It's a review paper. Dr. Rashid is the first author here in academic pathology. But effectively, you'll see here that it's a 4-step process at minimum. We've deconstructed down to the 4 steps to keep it simple for everyone. But it really involves, first part is knowing what data you have, how good it is. You then apply it to an artificial intelligence model or machine learning model. You validate it internally. You identify optimal parameters. And then step 3, you assess for its generalizability. And lastly, you verify the performance in the real world. And we'll go through each of these right now. So how good is your data? That's the most important question you should ask. As we know in healthcare, the electronic medical record varies in the quality of data. Most EMRs today are designed to optimize billing rather than really to help with patient care. People may disagree with me, but if anyone who has done clinical research and had tried to abstract data, it's not a great experience. But at the end of the day, you want to look at how valid the data is. Is it complete? Is there sufficient data points? So the density, is it potentially generalizable to other populations and other places? And how does it compare against real world versus research data sets? Because you could be using a clinical trial data set versus EMR data. So ultimately, the take home here is getting junk out. If you have bad data, you're going to make a bad AI. That's pretty much what it ends up being. But you also have to figure out how to convert data that is dirty, what we like to call dirta, so dirty data, to ultimately to clean data, and ultimately you have to ask yourself that question: how do we convert then that clean data to make it into actionable knowledge? So you have to find what is relevant and clean to move forward with these AI efforts. And then we have to validate and optimize. And validation and optimization is always a balance between fitting, overfitting, and underfitting it to an AI model. If you're over or underfitting a model, as you can see here with the bottom row below model complexity, you don't match the data. When you try to match it too much or don't match it sufficiently, the error rates get significantly high. So finding that sweet spot where you find that nice balance between variance versus bias and the error rate really helps decide the best model to move forward with. And that really comes down to somewhat of empiricism, but there may be new technologies in the future that help do this more automatically. But at the end of the day, it's like Goldilocks, finding the model that is just right. And then last, and certainly not least, assessing the generalizability of the model and verifying if it works in the real world. And of course, generalizability is hugely important. Showing the slide here from the same review paper that we have, we bring in more data, Can our data set in, for example, in pediatrics be translated to adults or vice versa? Can our data at UC Davis be translated to our colleagues in San Diego? Those are generalizability studies that we have to do. And also, most importantly, once we determine that it can be generalizable on research data, can it work in the real world where there's a lot of incompleteness in data sets, such as from the electronic medical records and so forth? And it emphasizes this important do these cross-validation studies where training data sets, additional secondary data sets are brought in to further validate and ultimately deploy in the real world. So the question comes up is, despite our great intents for patient safety, trying to improve the quality of patient care, and our innovativeness in using artificial intelligence, how far have we gotten in terms of AI? Unfortunately, the real world is a tough place. And here's a great article from MD Anderson. And several years ago, MD Anderson taps IBM Watson. Remember, IBM Watson was that artificial intelligence that beat human players in Jeopardy. And their intent was to pretty much put this into what's called the Oncology Expert Advisor to help physicians target appropriate cancer therapy. And they stated, a new era of computing has emerged in which cognitive systems understands the context within users' questions, uncovers answers from big data, and improve in performance by continuously learning from experiences. And that's what machine learning and AI is all about. But the reality is, as the title implies, the real world is a tough place. It didn't work. It was a major setback for AI, and in this case, in medicine. And what was highlighted was, first, about $62 million was wasted without achieving goals. The group conceded that treating cancer is more complex than winning a trivia game, and the vast universe of medical knowledge may not be as significant as purveyors of AI make it out to be. So where do we go from here? How do we avoid the pitfalls that were encountered by MD Anderson as well as others? And how do we ultimately navigate this potential minefield of creating a safe but effective AI, ML in healthcare, especially in the laboratory? The answer is simple. Why don't we just look at the low-hanging fruit? Let's start small so we can learn. Let's learn how to crawl before we can walk and before we can run. So with that said, we decided to go down the pathway of evaluating AI in a high-risk population. And this is burn patients. And burn patients in particular are at extreme risk for sepsis. Burn sepsis occurs frequently in burn patients because of the fact they've lost their primary barrier to the environment. So your skin plays a big role in preventing infections, as you can imagine. The majority of burn-related deaths are due to sepsis. Multi-organ dysfunction is actually the most common. About 97% of burn patients experience sepsis in their stay or some sort of infection. So early recognition is difficult because despite the that we sit through every year a new definition for sepsis, and I am exaggerating, every couple of years. The problem is these definitions for sepsis that we know and love in non-burn patients don't really apply. This is because of the fact that burn patients have severe tissue injury, they're hypermetabolic, and there's massive inflammation. To highlight this, as you can see, these are old and new definitions of regular sepsis in non-burn patients. And you can see here that recall what's called SIRS, S-I-R-S, or the Systemic Inflammatory Response Syndrome, where they tell you if you're hypothermic or hyperthermic with a temperature greater than 38 degrees Celsius for fever, you have a heart rate of greater than 90 beats per minute, a respiratory rate of greater than 20 breaths per minute, really high or really low white cell counts also suggest that you have an inflammatory response going on. And then if you meet any of these criteria on the left, where you have a presumed or identified source of infection, with these SIRS criteria and others, you have sepsis. And that's pretty straightforward. But the reality is, though, as we move forward and looking on this next line right here, the baseline profile of an acutely burned patient, they have a temperature of 38 to 39 degrees Celsius. They are always febrile, quote unquote. They always have 90 to 110 beats per minute for their heart rate. They're always breathing faster. And their white cell counts are can be really high or really low. This is due to the inflammatory response. So when you have these confounding factors and the fact that burn patients all exhibit SIRS, we have a problem in teasing out the one sepsis patient, 20 that are just inflamed. And this is a potential AI ML opportunity. So we decided to look at a unique data set that we had at Davis. We had the opportunity, I was the principal investigator for this, was to do a multi-center randomized trial. In this case, it looked at sepsis and used technology to detect infections more quickly. We had 218 patients from 4 burn centers. Davis was included, as you can see here on the left. And this served as a nice data set in addition to accomplishing what we did for the grant for the new device we were testing. We now have a large, very clean data set with all these test parameters, these vital signs, and other things paired to these patients across 218 adult patients with 20% or more. And just to highlight, a percent area burn for you or I is roughly about one side of your hand. So a 20% burn, it's comparable to a little bit more than both your arms being burned. Obviously, people may be burned in different places of their body. So our first attempt here, and we'll go into more detail about these techniques, is that we looked at if an AI ML technique could do better than a regular physician predicting burn sepsis. And it shows with this receiver operator characteristic curves, it actually had areas underneath these curves of about 0.68 to 0.86. Obviously, the one with 0.86, the bigger one, is better. This is a paper we just have submitted. And these are the variables we looked at for these burn patients. The sensitivity was 96% with specificity of 76%, so it serves as a great screening tool. And compared to traditional statistical methods that were used to help define current burn metrics of sepsis, the specificity was actually 84 to 62% for these old techniques. So we were more sensitive and more specific, which is fantastic. But during this process, we also realized that a lot of burn patients with sepsis, or even without, acquired a significant amount of acute kidney injury. In fact, 45% of these burn patients in our 218 patient data set had acute kidney injury. And yes, sepsis was fun. We showed good data and we're continuing to move on it, but it isn't really low-hanging fruit. Sepsis is quite dangerous in terms of misidentifying. So this revelation allowed us to refocus and go, let's first look at AKI first, because AKI is common secondary to sepsis as well as burn injury. So let's now look at a model for using AI for AKI. So this paper published in 2015, we did something novel. This is a paper published by Dr. Soman Sen. He's my colleague, and I was the last author in this paper because it was a study funded under one of our grants. And just to get folks on the same page, acute kidney injury is obviously direct damage to the kidneys, whether it be due to lack of blood flow, so pre-renal causes, direct damage to the nephrons and the actual parenchyma of the kidney, so intrinsic pathways. There's blockage that prevents urinary elimination. So common causes of AKI, of course, are sepsis, nephrotoxic medications, which occur from the antibiotics we give due to sepsis, as well as something called burn shock, which we'll elaborate very shortly. A study by Tina Palmieri, who's our burn director at Davis, showed that up to 58% of burn patients experience AKI. So it's a high prevalence disease. So going down the pipeline, we decided to look at 30 patients. These are all adults, again, with equal or more than 20% total body surface area burns. And the important thing to realize is that some of these patients will be getting AKI or not. The reason why patients are at risk for AKI, especially in the early days of admission, is they get what's called burn shock. Because of the systemic inflammation, there's massive vasodilation, which reduces their blood pressure. But also this is confounded by the lack of skin, where the skin also keeps our water in. So through convective and evaporative water loss, the patients lose a lot of volume and therefore become extremely hypotensive, hence burn shock. So there isn't a need to be able to look at burn patients in the first 48 hours to determine if they're at risk for AKI. So you can see the two populations here. We don't know which. The current paradigm for AKI is what's called the KDIGO criteria, which is not represented here. This is the original RIFLE criteria, which is an acronym for risk, injury, failure, loss, and end-stage renal disease. As you move down that rifle acronym, and the risk and severity is based on how much you urinate per hour or your GFR, your glomerular filtration rate. Obviously, as those deviate from normal, you don't look so well. So in this study, we found that 14 patients were categorized as having AKI, and then the remaining 16 out of 30 did not. So this is based on chart review and based on the rifle criteria. Quickly, the demographics for these two populations were similar. Age, burn size, gender ratios were similar. But I do want to note that AKI patients, despite having kidney injury in the first 48, within that first week, but in the first 48 hours of data, their creatinine, their mean arterial pressure, their central venous pressure, and urine output were statistically similar to the non-AKI population. So somehow after 2 days, these patients convert over and the kidney injury fully manifests itself in that first week. However, you do identify if you use a biomarker called NGAL, and we'll talk about what that is shortly. NGAL biomarker is statistically significantly higher in AKI patients within that first 48 hours than non-AKI patients. NGAL is an abbreviation for what's called neutrophil gelatinase associated lipocalin, and you can see here that it is produced by neutrophils, hence the name. It's filtered by the kidney, but during injury, because of filtration decrease, the neutrophil gelatinase associated lipocalin levels rise in plasma, and uniquely, renal tubular cells start producing NGAL as well. So you'll have more in the urine, coming back in the urine, or coming out in the urine and coming back into the bloodstream too. In addition to all of that is being produced by neutrophils. So NGAL becomes a very sensitive and specific biomarker for AKI. So we decided to use that data set, and it's been augmented, and was recently accepted and published in a 2019 paper in Burns. So it just came out. And we decided to use that data that is augmented by an additional 23 patients. We had NGAL, but also augmented across all 53 samples with N-terminal pro-BNP testing, which assesses the cardiac stress that is due to cardiorenal syndrome from AKI. Obviously, we do NGAL. We also do creatinine. Remember, the 30 patients are from the last population. And we can differentiate artificial intelligence. What we found in this, using AI, we were able to identify AKI a lot earlier. In fact, about 42.7 hours earlier. You can see the two groups here. You actually split out 50-50 quite well. Excuse me. But again, demographics were similar between the two populations. Urine output were not helpful. And you also note up there that, again, plasma NGAL was significantly higher in this population. Looking at ROC curves, excuse me, ROC curves, BNP and NGAL were the superstars here, with areas on the curve for this ROC curve of 0.83 and 0.9 respectively. NGAL performed well on its own as well. So we hypothesize here that both NGAL and BNP may work well together. Excuse me. So what approaches did we use? Well, the main approaches that we originally looked at, and we've moved beyond this in recent times, is looking at K-nearest neighbor, random forest, and support vector machine. K-nearest neighbor is effectively a technique where we cluster the data based on their outcome, AKI or not. We define an area to divide them in and see how far they are from that point. You can see there. So we want to classify red dots versus black dots in that case. Random forest effectively generates a random series of decision trees, and then through voting, composite voting or ensemble voting in this case, whichever is the majority wins, and therefore it votes who has AKI or not based on, again, randomly generated algorithms. Support vector machine, a little bit fancier technology or technique in this case. You can see that sometimes data doesn't spread nicely, doesn't divide evenly between some X and Y plane. And you can see here that, you know, red dots and black dots are separated reasonably well in the top left of the support vector machine figure, but there's still a black dot sitting in that area. So the support vector machine can then generate a contour line. You can see that bottom figure right there. It separates things out a little bit nicely, but again, it still having issues with fully separating it out. So you can use fancy techniques, a kernel trick in this case, is just fancy math, to then convert this to a 3D plane so that you can actually separate things out more in a 3D space rather than a two-dimensional graph. For this first paper, we only use K nearest neighbors just to try it out. And through this process, and K tells you how many neighbors you cluster the data. Ultimately, you can see here that the data, when we trained it and then tested it to validate it, it actually performed well after a certain number of neighbors. So x-axis is K value, so the number of neighbors. You can see that on the y-axis is the percent accuracy. And the take-home was that if we actually had a model that used NGAL, BNP, creatinine, urine output, NGAL, creatinine, and alone, the models work reasonably well with accuracies in the range of 90% and above. However, when you exclude NGAL, the models get progressively worse. In fact, if you remove BNP and NGAL altogether, you ultimately have creatinine and urine output, and you can see how terrible the performance is in panel D. So ultimately, this allows us to be able to know that these models can augment the performance of existing biomarkers, such as with NGAL, creatinine, and urine output, or BNP, creatinine, and urine output. But creatinine and urine output alone are not good enough, even though they're used as criteria for AKI today. So focusing on that model right there, again, we lack NGAL, but looking closer, we're achieving, and in terms of the orange line, that's what we use to validate. Blue line was what we used to train the data set. We are able to achieve roughly 90% accuracy across the board for most of these parameters without NGAL alone. So we don't necessarily need NGAL. NGAL helps. It does augment it. But if you're a place that doesn't have NGAL, you can use AI to augment its existing performance, which is a very interesting tool. This then brings up the hypothesis then, could we actually deploy AI early using these combinations of biomarkers to differentiate patients earlier, hence being able to predict AKI with artificial intelligence about 2 days earlier than traditional techniques. So this moves us next to the next paper we had it. And in this case, this is where we focus on the generalization of the burn data. We decided to move beyond K nearest neighbors. We still used it, but then include the two other techniques as outlined here, random forest and support vector machine. We did a much larger data set. So this initial burn cohort of 50 patients, we analyzed it with the two other techniques, random forest and SVM. The accuracies, the average accuracy on the left, as well as the x-axis showing the different combination of biomarkers. And you can see that, again, we do see that phenomena using the three techniques now rather than just K nearest neighbors, that we can augment the performance without NGAL when using AI. But we now have a new cohort. We brought in an additional, in this case, you see that there are a combined burn trauma cohort. We decided to do this is because we want to stress test. We have a cohort or an AI that was trained only on burn patients. Let's see how it works when it has a mixed population of burned and non-burned patients. But again, we do see that there is better performance. And the reality here is that it actually AKI even earlier. So the last paper showed it was close to 2 days, about 42 hours earlier. Now we're able to predict it 61.8 hours earlier, including in patients that weren't even burned. So the conclusions I have for this is pretty straightforward. Artificial intelligence for burn-related sepsis and AKI is feasible. It works. It's just the data that you have. You have to make sure it's clean going in. Burn sepsis, AI appears to perform better than traditional indicators. And then AKI and machine learning augments the performance of these legacy biomarkers such as BNP, creatinine, and urine output. We actually also showed that if we have an AKI, artificial intelligence algorithm trained on burn data alone, it can work in non-burn trauma patients. However, we do caution that artificial intelligence is still in its infancy. Yes, there are cars out there that are semi-autonomously driving on their own. Yes, we have search engines and cameras and game show winners that are based on AI. But in healthcare, there's still a lot we have to resolve. There are obviously the technological challenges, but also the sociological challenges and regulatory barriers. Questions that have recently come up in papers in JAMA have asked, who's liable when you're using AI? Is it the person taking the decision, or is the person who made the AI? Lots of questions there. The quality of data and the appropriateness of how you validate these artificial intelligence and machine learning algorithms and how you utilize appropriate analytics are all critical in making sure that these new novel ways to analyze data, to make decisions, work safely and efficiently in the healthcare or the complex healthcare environment. So just to acknowledge, the burn data and pilot study data that you see here were from various grants. The Mentor Clinical Research Training Program at Davis was actually NIH funded. And the second data set was sponsored by the Internal Quality Project at UC Davis, deploying NGAL and AI for laboratory purposes. We are, in fact, actually expanding this and working to deploy it clinically after going through the appropriate process. So with that said, I'm happy to take questions from folks. I know this is a recorded presentation, so I believe I will see these questions in email, and I'll be delighted to respond back to your questions and comments. And thank you again for taking the time to hear this talk.